Hi, welcome back. I am Dr. Ellie Kraft, and today's topic we are going to talk about what to expect in your pathology report and on your imaging report. So, the pathology report is super, super important, and this is why we do biopsies before we go to surgery for breast cancers. So, there's all different types of breast cancers, different flavors, and the pathology report really helps us know which category this breast cancer is in, how advanced it is, and if it's generally a fast or slow growing tumor. That gives us a lot of information because treatment can change based on if the tumor is overall fast moving versus slow moving. So usually at the top line of any pathology report, it's going to name the tumor subtype. So this will say something like ductal carcinoma in situ, or invasive ductal carcinoma, or invasive lobular carcinoma. Those are the three most common pathologies that you will find on your report. And what these mean are different things. So if the pathology report says ductal carcinoma in situ, that means that the cancer is still inside of its shell. So it has not invaded the basement membrane of, again, we talked about these hollow trees that are found inside of the breast that aid in breastfeeding when we're of childbearing age. So these hollow trees can get full of atypical cells and turn into cancer cells. And as long as they're inside of their basement membrane, they are still classified as in situ. So that's one category that the pathology report can tell. Now, when something is thought to be only in situ, that means that the basement membrane is intact, and theoretically, the cancer cannot spread to the lymph nodes in those situations. Now, there are different situations where there's a lot of DCIS that, is greater than 5 centimeters inside of the breast that can kind of hide invasive disease inside of it. But we're not going to go into that in this video. But that is a caveat where we might not necessarily believe the core needle biopsy. Because I always tell patients, remember, if you have a mass that's maybe the size of a golf ball, and they go in with a tiny needle and take out 4 to 6 pieces that are just the width of that needle, you clearly can't get a complete representation of what's going on inside. Now, the smaller the mass is, the more likely that core needle biopsy is accurate, but it's always a possibility that the core needle biopsy is not necessarily exactly the same as what we would find in surgery. But don't focus on that point. That's just a caveat that I want people to be aware of, especially if they get a diagnosis of DCIS, but there's a large span of disease. So that means, like I said, more than 5 centimeters, and that's usually found on the pathology or on the radiology report. So that's the first category of the most common breast cancer that you can find on that first line that says tumor type. Now is ductal carcinoma in situ. Shorthand version for that is DCIS. Now, the second most common that we find is invasive ductal carcinoma. So this means that same DCIS situation where the breast cancer cells have stayed inside of the basement membrane, they've started to invade the basement membrane and go outside of that duct. And when that happens, the cancer cells can kind of build on each other, and in certain situations, they form a mass in that situation. So that's called invasive ductal carcinoma. And that invasion is happening inside of the branches of the trees. Now, invasive lobular carcinoma is when there's been invasion that's happening in the leafy areas of the trees. And again, it's an invasive process. So that means that the cancer cells have broken through the shell. And when that happens, our body's first line of defense, which is our lymph nodes, have the possibility to pick those cells up. So anytime someone has an invasive cancer, what your cancer doctor is going to be thinking about is, I wonder what the status of the lymph nodes are. Has the disease spread from the breast to the lymph nodes, or has it not? And they can gauge that based on a couple of things. So they can look at the imaging and see if there's any sign of lymph node, what's called cortical thickening. So if the what's the word? If the border of the lymph node or the capsule around the lymph node is thicker, if the cortex is thicker, then that can be a sign that cancer has invaded. But a lot of the time, it's very difficult for us to tell. Ultrasound is really the best imaging modality to check the lymph nodes, but MRI can pick it up as well, but it's not as sensitive as an ultrasound is. So ultrasound is definitely the test of choice to check the lymph nodes prior to surgery. Okay, so that's the first part of any pathology report is going to be the specific subtype. And the most common one overall is invasive ductal carcinoma. So for all of you listening, that's likely the diagnosis that you will be receiving. Lobular is also common, but not as common, and same with DCIS. It's also very common. So that's the first part of any pathology report. The second aspect is the grade. So grade does not mean stage. Grade just means that in this biopsy, how abnormal do the cells look? There is grade 1, grade 2, and grade 3. Grade 1 cells look very similar to regular breast cells. Grade 3 cells look very dissimilar to regular breast cells. And grade 2 is kind of a catch-all that doesn't really mean one thing or the other. So I often don't put much stock into a grade 2 tumor. Now, if something is grade 3, that tells me something. And if something is grade 1, that tells me something. But grade 2 is kind of a miserable middle and doesn't really sway anything one way or the other. Now, the other thing that people get very confused about is the tumor size is typically listed on this pathology report. That is not the size of the tumor. That is the size of the biopsy. So that just means how big of an area the biopsy took out. It does not mean that that's the overall size of your tumor. That is very confusing for patients, rightfully so. And so just know, unless it says, size of tumor from imaging, that's where we get the actual size. It's likely talking about the size of the biopsy. Okay? The next part that's really important are the tumor receptors. So these different tumor receptors, I like to describe as like on-off switches for the cancer. So there's 3 main tumor receptors that are found in breast cancer. So there is an estrogen receptor, there is a progesterone receptor, and there's a HER2 receptor. And these are given as percentages or positive or negative. So estrogen or progesterone is typically reported out as a percentage. And that means in the cancer cells that were biopsied, the percentage of them that had these receptors. So let's say you have a 95% estrogen receptor on your report. That means that 95% of your cancer cells had this estrogen receptor, which is an on switch for that cancer cell. So if you have extra circulating estrogen in your body, that could theoretically turn on the switch for that cancer cell and help it grow. Okay. Progesterone, same idea. So let's say you have a 95% estrogen receptor. That means that 95% of your specific breast cancer cells in that biopsy showed a progesterone receptor. And so if there's extra circulating progesterone, same idea. It could switch those cancer cells on and help them grow. Now, HER2 is typically reported as positive or negative. It's not reported as a percentage. And if that is negative, that's the more common situation. A HER2 negative cancer is the most common. And a HER2 positive is more rare, but we definitely do see that in the population. And whenever the HER2 is positive, that does tell us that your specific cancer tumor cells have a HER2 receptor on them. So they can be turned on or off by that HER2 receptor. Okay, so those are the 3 main receptors that will be on also every pathology report for breast cancer. Now, the fourth piece here that really tells us about the speed of the tumor is called Ki-67. And that number I like to describe to patients as like a gauge of speed. And it also goes from 0 to 100. So the closer it is to 100, the faster it is. The closer it is to 0, the slower it is. And basically, it tells us if the tumor is, closer to 100, we know that this tumor is likely faster moving and might benefit more from something like chemotherapy, which works really well in fast moving tumors. Versus if this is a low number, if this is closer to 0, it likely wouldn't have much benefit from chemo, but it's not a set in stone test. Basically, there are more specific tests or better tests that happen after surgery that give us a more accurate and precise indication for that, called an oncotype or a mammoprint. At this time, those are what the tests are called that offer that. And what those tests do is basically they look at the tumor itself once it's removed from the body, once it's removed at the time of surgery. They send off the most aggressive part of that tumor and check it for various genes that put it at high risk of coming back in the future or recurring. So those tests that typically happen after surgery are a more definitive and specific indication for chemotherapy. They are the standard of care. The Ki-67 is a good gauge of that beforehand, but the oncotype or mammoprint are really the standard tests that actually guide our decision making on if someone benefits from chemo or not. So those are the main parts of the pathology report that you will see, and your cancer doctor should definitely be going through with you. Now, the second part of that you're going to talk about in that appointment is the imaging. And why the imaging is important is because it gives us the size of the tumor to our best ability. Now, there's 3 types of imaging. There is mammogram, there is ultrasound, and there is MRI. And especially in cancer or breast cancer in particular, it's ideal if you can have all 3 tests. Now, not every place has that availability. MRIs especially are very hard to access in certain places. So sometimes, a mammogram and ultrasound will be sufficient if you don't have access to MRI. But I like to describe all 3 of those imaging modalities like a knife, a fork, a knife, a fork, and a spoon. So, right, they all are used in different ways. Not one tool can be the definitive tool. They all 3 work together to give you the information that you need. Now, mammograms are great at finding calcifications, which look like little grains of sand. They're also great at picking up things like architectural distortion or asymmetries. Those are little subtle changes that radiologists can pick up on. And that's what those tests are great at seeing. That's what the mammogram is great at seeing. What an ultrasound is great at seeing are masses. And there's a lot of cancers that can see something on a mammogram, but nothing on the ultrasound, and vice versa. So that's why it's important to have both tests, because you can get a really solid lay of the land. Now, the third test is the MRI. And I like to describe the MRI as like the highest definition HD view, your 4D television kind of thing. So it really looks at under the hood at everything. And its main benefit is seeing something called non-mass enhancement. And what non-mass enhancement means is exactly those words. So there's not a mass there, but there is brightness that appears on the MRI that is typically disease, but it does also have the ability to overcall things. It has about a 30% chance of requiring a biopsy for something that wasn't actually cancer. However, it can also pick up things that you can't see on any other imaging. And now, especially in a cancer like lobular cancer, an MRI is crucial because it often picks up disease that the mammogram or ultrasound cannot see. So those are the 3 tests that the majority of breast cancer patients are going to be getting beforehand, and this is why they're important. Now, so many patients, like I said, don't always have access to that MRI, so it's more of just a added bonus in certain areas of the country. But if you're in a place where you can get an MRI, I would absolutely fight for that if you do have access to it. And it's just a matter of, calling around or finding different places. And so the imaging, once you have all those pieces of imaging, you can really put together an overall size of the tumor, because the size helps us determine the stage. And so remember, the stage has 3 components. So the first component is the tumor size. So stage 1 has a size of less than 2 centimeters. Stage 2 has a size of 2 to 5 centimeters. Stage 3 has a size of greater than 5 centimeters. And that's the size component for the tumor aspect. Now, the second component of staging is nodal spread. So if you have just the nodes in your lymph nodes involved, that's a certain stage, versus if it spreads outside of the lymph nodes or outside of the axillary lymph nodes to other parts of the body, that can upstage you. And ultimately, if there's tumor spread that's outside of the regional area of the breast or axilla, that can be considered a higher stage or stage 4. But it depends. There's very different nuances for the disease spread. So again, you would talk to your doctor about all of that. And that distant spread can be evaluated by something like a PET CT scan or a CT chest, abdomen, and pelvis. And, those tests are not always recommended, especially for small, slow growing tumors. It's only when we're very concerned for a stage 4 situation that the PET scan or the CT scan is typically ordered. So, those are the things to know about the pathology report, about your imaging report. And the caveat here, of course, is, this is not medical advice. This is purely for education purposes. This is so, you can start looking at your pathology report and getting an idea of what everything means. And then the job of your doctor taking care of you is to really walk you through your specific breast cancer and what that means for you, and how the imaging and the biopsy are determining your treatment. Okay, so that's what I wanted to talk about today. Thank you so much for joining me, and we will be back soon.